My name is Miyagi Solbeck, and I'm a pediatric anesthesiologist and a PhD candidate in medical education at the University Hospitals of Geneva. The article I'm discussing today is titled Gender Disparities in AI-Generated Images of Hospital Leadership in the United States, and it will appear in Mayo Clinic Proceedings, Digital Health. The key takeaways is that AI-generated images of hospital leadership in the US significantly overrepresent men and white individuals, failing to reflect real-world diversity. This highlights how AI can perpetuate and even amplify existing systemic biases unless explicitly designed to promote equity and inclusion. Our study analyzed 1,200 AI-generated images representing hospital C-suite's role using three major text-to-image models, DALL-E, Midjourney, and Imagen from Google. We compared the demographic portrayals in these images to actual gender and race ethnicity distribution in US hospital leadership. We found that all models, especially DALL-E, overrepresented male and white individuals. Imagen performed better in terms of gender balance, but still lacked racial diversity. These disparities underscore how AI model can mirror or worsen societal biases, especially when trained on non-representative datasets. These findings relate to clinical practice because AI tools are increasingly being integrated into healthcare, not just for diagnostics, but also in visual communication and public-facing content. If these tools depict leadership in a biased manner, they risk reinforcing stereotypes about who belongs in positions of authority. This can subtly shape perception within clinical teams and patients alike, influencing both organizational culture and trust in care settings. For patients, especially those from underrepresented groups, this bias representation can erode trust and reinforce feelings of exclusion. Diverse and accurate depiction in AI-generated content help foster a sense of belonging and representation, which are important elements in building trust and improving healthcare outcomes across communities. The next step is to explore solutions. We need to evaluate the effectiveness of fairness-aware algorithms, inclusive training datasets, and regulatory frameworks in mitigating AI bias. Future studies should also assess intersectional biases and extend this work to global context. Ultimately, collaboration between AI developers, healthcare institutions, and policymakers is essential to create ethical representative AI in medicine. Thank you for your time. The authors and I encourage you to read our paper.